We have now arrived at the final session of the day, a session that, appropriate enough, brings together the voices of nurses for a discussion entitled, "What is to be done? Nursing through a Pandemic." We are pleased to be joined in alphabetical order by Danielle Bourque-Bearskin, Keisha Jefferies, Haniely Pableo, Connie and Martha Paynter. Each of these ladies will have about 5 minutes to introduce themselves and to address the following question. What are some of the key challenges that you have encountered in your work practice during this period? You are welcome to interpret this in whatever way you decide. In the main, the question is referring to the pandemic. But of course, the pandemic has surfaced so many social and political issues and is occurring in the midst of profound social and political movements here and across countless geographies. After each of you have spoken, we will give all of you an opportunity to respond to what the other panelists have said. Following this, time permitting, we will invite questions and comments from the audience. So I'm going to start with Danielle, and if you would like to introduce yourself and help us understand what are some of the key challenges you have encountered in your work or practice during this period.
Can everybody hear me? Perfect. Okay, wonderful. Danielle Bourque-Bearskin Nagastuin, Beaver Lake Cree Nation, Nahau Isquail, Ochinia Territory 6. So my name's Danielle Bourque-Bearskin, and I am a Plains Cree woman from Beaver Lake Cree Nation and Treaty 6, which is also known as Alberta. And I'm currently situated here in the Dish with One Spoon Wampum Belt Agreement, known as Hamilton, Ontario, and the whole land of the Haudenosaunee and Mississaugas of the Credit people. And thanks, it's wonderful to be here. And thank you, Rosemary, for your talk on gender and the beautiful song. I was dancing to it. And my background is in nursing, and I think I have a unique perspective in answering this question because not only am I an Indigenous healthcare provider, but I'm working currently in an intensive care unit here. And but since the beginning of this pandemic, I've also I've been working in a remote First Nations community in northern Ontario as a community health nurse, and that's what I'm going to focus on in discussing these challenges for this panel today. Which some of those challenges we face in the community that's made responding to this pandemic and preventing the spread of COVID incredibly difficult. And those are because of the socioeconomic factors that have been present for decades in our Indigenous communities across Canada. For instance, overcrowding and lack of housing and poverty are all issues Indigenous communities face across Canada, but poses the question how we can quarantine and isolate individuals who are in households with 10 or more family members, and some of which include our elders and our knowledge keepers. And how do we protect those individuals from harm? And we've had to repurpose buildings such as schools and community health centers to house these people. So that housing crisis is responding to this pandemic a challenge. And lack of access to clean drinking water is another issue. The community that I'm situated in has been on a boil water advisory since the early 2000s. And so again, how do we follow Canada's public health guidelines when access to clean water is a challenge, and the water that we do have access to is contaminated with bacteria and harsh chemicals. So many different challenges. One of the biggest assets in responding to this pandemic has been the aggressive approach taken by our community leadership, and such as travel bans to medically essential travel only. However, these restrictions that have been put in place definitely have exacerbated many of the health problems that our communities have been struggling with for a while. For example, the travel bans implemented early on had a direct impact on the mental health of many communities, even seeing an increased rise in mental health crises where I'm at. And this pandemic has truly had a tremendous impact, I think, for many Canadians on our mental health. But in our communities pre-pandemic, this crisis has we've been struggling with this mental health crisis, and it remains a challenge today because of the lack of healthcare resources. For example, the nearest mental health facility for our youth is in Sioux Lookout or Thunder Bay, and it just goes to show that we as nurses have access to the bare minimum resources in these communities, and it's exacerbated by COVID. And the last challenge that I'll talk about is what we faced with policies and procedures put forward by non-Indigenous organizations. For example, Medevac services such as Orange have had policies at one time or another during this pandemic that prevented or limited escorts on Medevac flights. So our community members that are already vulnerable leaving these communities with these health issues are expected to do so without a health advocate or sorry, my voice is getting really dry, but so our community members are expected to fly out with no health advocate or support person, and this poses a serious risk on their health due to medical racism and that cycle of harm present in our healthcare system. Brian Sinclair and Joyce Akwan are tragic examples of the cycle of harm and what our people endure on a daily basis due to discrimination. And this can even be seen at our own nursing station in the communities where there is fear in accessing health services. And it's also exacerbated due to COVID, and this has led to an increased delay in accessing care, which was already a problem for our people. And it also just reaffirms that there's still a great deal of mistrust between Indigenous and non-Indigenous healthcare providers. And factors that I can consider that feed into that mistrust is the high rates of staff turnover, lack of nursing staff in our communities, and the lack of health services that are delivered or tailored to the needs of our Indigenous people. And so bottom line, it kind of just, as Dr. Morgan had said, this pandemic didn't discover the health inequities, these gross inadequacies in healthcare. It just brought them to the surface, and hard for the public to ignore the unequitable healthcare that Indigenous people receive. So I'll leave it at that.
So my name is Keisha Jefferies. I am a registered nurse and a PhD candidate at the School of Nursing at Dalhousie University. I'm also an African Nova Scotian woman, so a member of the historically Black group that resides in Nova Scotia and has historical and lineage connections to the land there. I have clinical experience in neonatal nursing as well as breastfeeding, maternal newborn care. And finally, I'll just talk a little bit about my master's work before getting into some of the projects, the advocacy and the research work that I'm involved in, and then finally talking about how I'm impacted by the pandemic and how I view challenges related to the work that I do. So for my master's, I did a health policy analysis in Tanzania. So that involved analyzing breastfeeding policies in the country to understand what was going on with exclusive breastfeeding practices. So I did spend 3 months in Tanzania. And some of the work that I'm currently involved in, so fortunately I am in a position where I'm able to do most of my work from home. So while I am from Nova Scotia, I'm currently based in Toronto. So just to speak about my PhD research, that's a qualitative analysis that is looking at the leadership experiences of African Nova Scotian nurses. So it's using a Black feminist and critical discourse methodology to really uncover the perceptions of nursing leadership and also how nursing leadership is actually practiced amongst African Nova Scotian nurses. Currently, I completed my data collection during the pandemic, so I was able to interview 18 African Nova Scotian nurses, which is quite significant. So I'm getting ready to do the data analysis on that. And So I'm obviously looking at ways to influence institutional policy and organizational policy to increase representation of African Nova Scotian nurses in the healthcare system, but also to address a lot of the inequities that exist within the African Nova Scotian community and the larger Black community across Canada. Some of the other work that I'm currently involved in, so in addition to looking at what was going on with African Nova Scotian nurses, I ended up discovering that there's a significant issue with representation at the student body level. So there's underrepresentation of Black students in the nursing program, not just in Nova Scotia at Dalhousie, but across Canada. So currently at Dalhousie, we're working on an equitable admissions policy to address inequities from historically marginalized groups. So this includes Indigenous people, Black people, queer individuals, as well as people with altered abilities. So we are ramping that up and trying to get that in place for the next application cycle, and then hopefully share that across several institutions to improve access to applicants and potential nurses across Canada from these historically underrepresented and marginalized groups. Another piece that I'm involved in is a scoping review that is looking to synthesize and consolidate the existing evidence related to African Canadian nurses. So looking to bring this forth and then hopefully get that information into the hands of nursing organizations, but also community groups to really push for and advocate for ensuring the representation of racially diverse people in institutions. I'm just trying to highlight some of the big ones. And then just this other piece. So there's also a food security scoping review, which is looking at food security issues. So we know that this is a problem. This is one of the challenges within Canada. So food security, Canada is not food secure for many of our marginalized groups, as we know. So we are working to identify what are the gaps, what are some of the potential opportunities for addressing a lot of the food insecurity that exists within the Black community in Canada. And finally, I won't talk about the prison abolition piece because I believe co-panelists will get into that. But finally, I'm also involved in a lot of mentorship at Dalhousie as well. So this is coming through in the community of Black students in nursing. So this is an initiative that began in 2017, and it is a student-led peer mentoring organization that is really designed to assist students in navigating through the nursing program. So I did work with another individual to start this up. However, as new students are coming into the program and taking on very robust leadership roles, it is moving and changing hands, which is really exciting. So it's building that capacity within students and within the community. And then finally, I'll just touch on one of the challenges that, kind of covers a lot of aspects that I've experienced during COVID. And that really relates to the idea of Black tax. So the fact that Black individuals, Black researchers, Black academics, there's just this extra layer of stress and burden that comes with being an academic, just related to your race. And then if you want to throw intersectionality in there, your race and your gender and your sexuality and others. So the idea that racism is in itself a pandemic that has been going on for, since Black people arrived in Canada, and then prior to that, the grotesque treatment of Indigenous peoples on this land, we know that there is the race pandemic has tremendous influence and impact on individuals. So when you add a virus that is COVID-19 in the mix, as Danielle mentioned previously, it's not that new inequities are being created, it's simply that these are being exposed. We have in Canada many challenges, many issues that I believe are fixable and fixable quickly, yet we are complacent as Canadians. Our niceness is apparently enough to allow us to move about our day and not address a lot of the inequities that have been existing for multiple years. So for me, as I mentioned, I am fortunate enough to work from home and do a lot of this work, but the burden of witnessing trauma porn as you're doing your work. So you're seeing a lot of these very graphic videos, a lot of this information, hearing harmful commentary, it is very mentally straining and physically straining. So that is also a discussion amongst a lot of scholars who engage in this work. So the exhaustion that comes from constantly having to be connected to the trauma that is happening. So as a helper, as a nurse, you are involved in whether it's generating evidence, taking care of patients, or just doing presentations. You're doing all of this work, but at the same time, it's balancing and managing your own mental health and physical health. Because just speaking from personal experience, you know, it begins as a mental issue. It may begin as anxiety, but then it transforms physically in your body. So then you do experience these physical manifestations of a lot of this trauma. So it's really been the challenge of balancing self-care and the work. So I'll stop there.
Thank you very much, Keisha. I appreciate your insight into trying to balance, which is very difficult. I appreciate that. I'll turn now to Hanalee. Thank you very much for your video. It certainly resonated with many people. So thank you very much. Go ahead.
Hello, everyone. My name is Haniely Pableo, and I go by Han as an artist. I'm a registered nurse. I'm actually an internationally educated nurse. And when I came to Canada, I had to go back to school and get my RN degree. And at the same time, I have clinical experiences in medical surgical floors, spinal cord rehabilitation. But right now I work as a operative nurse. I work in the operating room, specializing in cardiac surgery in Toronto. I'm based in Toronto. And during the first wave of the pandemic in April, March, I volunteered to be part of the emergency response intubation team in our hospital. So we're basically the ones who go directly to the patient when they need airway management. And it's been it was a great experience and a great learning for me personally. And this pandemic, the challenges that I would focus more on is that more on the personal level and on the community level. And on a personal level, this pandemic has pretty much highlighted the importance of self-care, not just for the patients that we take care of, but for us as well as healthcare workers. The importance of the arts as a channel and a medium to express, and it's also an act of self-care, and also the importance of live music for me personally. I've had gigs that had been canceled, but that's okay. And also, it's for me in a community level. I come from a community of racialized women and men, and in between. And Canada historically has been reliant on migrant workers for essential services. And yet I feel like those migrant workers for a very long time has had inadequate protection and rights. My mom was a live-in caregiver, and that's basically the reason why I'm here in Canada. So issues with migrant workers is pretty close to my heart, because this COVID-19 has sort of like showed us the weaknesses in the system, in the Canadian healthcare system and the social institution in general. A lot of the people I know personally and also within the community who are here in Canada have families back home in the Philippines, just like me and my family. And a lot of them, including my family, would send remittances to our families in the Philippines. And because of the job loss of some of the people in the community, that sort of like affected economically. And also, there's a lot of this the disproportionate effects of the pandemic on the racialized groups and not just Filipinos, I would say. And this pandemic has definitely highlighted those disparities. And I would agree with the other presenters that there needs to be collection of data so that we can identify those issues and problems and those vulnerable population that we can focus on with our intervention moving forward. And I would just like to say that the biggest challenge for me is the adaptation to the constant changes that we have personally where I work, because every day there's a different protocol. Especially during the first wave, we didn't have enough PPE. We were there's just different changes every day. It's a different changes. So, but we're used to that as nurses. And right now we're on the second wave in Toronto, and we're currently on lockdown as well. So it's also very busy in the hospital because we're also not dealing with just COVID. We're also dealing with other healthcare issues, especially we're quite busy right now. We have a lot of cardiac cases. And our RCUs are almost overcrowded. And but we move through. That's why I'm really happy that I'm invited to be part of this conference, and it's a really well represented conference. So thank you to the organizing committee for having us. And I'm going to leave it at that so that I can leave more room for question and answer. Thank you.
Thank you very much, Hanalee. And we do very much, as Canadians, value the work of our internationally educated nurses or migrant workers. And we here in BCNU are very proud that you're a member of our, well, you not, but we have IENs who are members of the BCNU and the value they bring to our organization and to our profession. So thank you. I am going to turn it over now to Connie Paul.
CI. My Indigenous name is Thalthithuit. I am here right now presently in the Sanémoc First Nations, and I welcome each to this circle. I really want to thank the speakers for asking me to speak. I've been a home and community care nurse working in First Nation communities for 32 years. Of those 32 years, I did 18 and a half years as an outpost nurse. I've worked in the Sanémoc Nation now for 10 years as a nursing manager. And when I was asked about the question around COVID, COVID sheds light on any of our weakest links that we have within our nation and within our relationship, trying to merge the federal government programs and services with the provincial services. One of the great relationships that we always have to consider is our CDC and our local hospitals. I really want to thank the worker that says she works and intubates our members. In our nation, we lift our hands up to your work. So thank you for doing that for us. I really want to shed light on our leadership. They've taken a really strong role in health, which has been absolutely delightful. It's the first time I've seen leadership stand up and recognize that if they want to protect our elders, and there's so few of them, when you're looking at the life expectancy of an Indigenous person, it's 5-10 years less than the average Canadian citizen. So we have few elders, and we need to do everything we can to protect them. So our nation has really moved forward with doing community videos, trying to reach out to our elders and trying to find a relationship between traditional teachings and how do you take those traditional teachings and find a way to blend them with Western colonial ideas around viruses, and bacteria and cleaning, and that's been a unique challenge. If you can imagine in a community, there's only 2 nurses here. So in a hospital, you have somebody creating all the policies and procedures and guidelines for coming into a health center. You're the one that's going to create all the guidelines and procedures. You're the one that, will sit down, with the band administrator and saying, we need to wash our hands, or we need to use masks. Where do you get masks from? How many masks do you need? How many you need, who's going to wear the masks? What kind of masks are you going to wear? So everything from the most basic, that's what's unique about working in a First Nations community, is that you're the individual. When COVID started, it was like, what does this mean for the nation? What does this mean for leadership? What does this mean for, how people come in and out of our nation? So that's been unique work. I've never had to do that kind of work where I've had to do so much reading, translating, and then working with leadership to create policy. So that's some of the work, on a day-to-day basis that's within our nation. Over top of all of that, you always have to recognize that as an Indigenous person, there is systemic racism, and there is issues within the system. And how do you work with leadership to address those issues? How do you create change outside of the area that you work in? So I've watched the newspapers and the Facebook and what's being said on the news. And I agree, how do we hold each other accountable? We had a situation here on Vancouver Island where a hospital and doctors and nurses, were betting on the alcohol level of an Indigenous person that was coming in through the emerge department. How do we hold each other accountable during these stressful times? I watched the national news where an Indigenous woman died on the emergency table, and the nurses and the workers that cared for her. It's tragically sad. So we have a responsibility as nurses to hold each other accountable for our standards, to not stand by and silently accept that unhealthy behavior. I'm not sure why those workers felt that way, why they felt that they were racist and unkind. So those things need to be addressed, and I think that can be done in the educational system at universities. For myself, I sit at a couple of tables. I sit at a university table, and I really want to see that we've done truth and reconciliation in education. What does that mean? That means we've acknowledged here in Canada that there were Indian residential schools. How many people know that here in BC we had segregated healthcare, segregated hospitals? Here in Nanaimo we have the Indian Hospital. We have Kukulitsa Indian Hospital. We have Sardis Indian Hospital. We have a hospital up in up northern in Port Hardy. So how do we address that historically existed till 1965? That those systems segregated us from healthcare from other Canadians. How many people, know about the tripartite agreement on Indigenous health, that it's only been in the last, I'd say 15 years where the province healthcare nurses come on reserve. When I started 32 years ago, Island Health did not come on reserve. So that left the one nurse to do all the care in community. So I think it's important that nurses know the history of nurses and the history of how care was delivered to the Indigenous people. COVID is only part of, it shed light on the disparity of much of what's happening in First Nation communities. Aside from COVID, we have the homeless problem, and we also have the drug overdoses, the COVID and carfentanil. We've carried people home in boxes, and that's tragically sad. We've lost more people to IV drugs than we have to COVID in our community. Our community's been fortunate. We haven't had any positive cases, but I think that's part in that our chief has really had a lockdown in our community and did everything he could to protect the frail and the young in our community. So when I look at challenges and you say COVID, for me, the challenges are homelessness, poverty. Our people are still afraid to go into a hospital, and with lockdown, they're even more afraid because they can't have an advocate beside them in the ER department. So that further isolates the clients. I have palliative care clients that do not want to go to the hospital because they don't want to die alone. And the restrictions, for palliative care has certainly had an impact. So we've really pushed hard to get physician services. The attachment level for the Indigenous people in this community, 5 years ago was 60% were unattached. That means they had no family doctor. And we're right next to the city. People live right across the street. Somebody mentioned water. This nation had cisterns. We drank from cisterns, but the main city water was across the street. That changed 4 years ago for us. So advocacy, when you're talking about the determinants of health for people, of our people, it's about making sure that our educational system teaches us what we should be knowing. This morning I was watching the news, and a teacher in grade 6 sent home an assignment for a grade 6 student. Name 5 positive things about the Indian residential school. That's tragic. That's tragic that is still happening, so we need to hold our educational systems accountable for how they teach about the history of Indigenous people in this country. So I've worked hard as a nurse. I sit on a table, the primary care network, trying to look towards solutions to have physicians in our community to meet with the basic needs of our clients that are unattached. Part of my role as a nurse, I say, give me a nurse for one day and I will change her practice for a lifetime. So my commitment to trying to create change is to have a mentorship program. For the past 10 years, nurses are welcome to come and walk with me for one day to see the work that's being done in our nation. So one of my goals is really, as a nurse, is to really teach young men and women around the culture, to have culturally informed practice, and truth and reconciliation in education, and to really try to get them to understand how to utilize non-insured health benefits in the healthcare system that tries to meet the needs of our people. So try to be part of the solution and not just identifying what the gaps are. So I really want to thank you for your time, CMCI, and I say Creator, thank each person that's come to this circle, that's taken the time to hear the stories that have been shared by the nurses here. And thank you for my giving the opportunity to speak here. Thank you, Creator, CMCI. Thank you very much.
Thank you very much, Connie. I appreciate you bringing us back to residential schools and the legacy that we still are living in this province. And yes, I too was aware of the school assignment and was horrified to hear that. So thank you for reminding us of the inequities that continue in this province and perhaps have only been highlighted even more through the pandemic. I'm going to go to our last speaker now, which is Martha Paynter. Martha?
All right, so my name is Martha Paynter. I am a white settler coming to you from the ancestral and unceded territory of the Mi'kmaq people. I'm at Dalhousie University, where I'm a PhD candidate with Keisha. We are study together there. I also work in clinical practice at our hospital-based abortion clinic and in the postpartum unit at our maternity hospital. So a reproductive health practice that spans those dimensions. And I, for 8 years now, have been very involved in advocacy work related to reproductive health and its intersection with justice, with criminalization. And my doctoral research looks at reproductive health outcomes for incarcerated women, trans, and non-binary people. How I have been affected by COVID, I think the most acute issue has been for 6 years. The organization that I coordinate, Wellness Within, provided doula support for people who were experiencing criminalization in pregnancy and postpartum. And as of March 13th, we have been locked out of the facilities. So those people are alone. They are unaccompanied, unattended. They're experiencing extreme segregation. Here in Nova Scotia, we made an enormous effort early in the pandemic. Really, the biggest push was over the Easter weekend to decarcerate, recognizing that incarceration is a preventable threat to health in a pandemic. We advocated, collaborated between the Crowns, the court, the Justice, Defense Council, community organizations, and using a trifecta model that balanced housing needs, economic security needs, and healthcare needs, made sure that people had what they needed and got them out. We decarcerated 42% of the people who were held in provincial prison. And that compares to the federal government decarcerated 2%. This was an extraordinary effort, extraordinarily successful, and yet when the funding dried up for the alternative housing that had been created, this very successful program, in the exact same moments as the whole world was chanting to defund police and work towards abolition, we found this program was defunded. And now, late November, the prisons are back up at the exact same numbers we saw at the beginning of the pandemic. And here on the East Coast, we're now just a couple weeks into our second wave, really beginning to feel the crunch, and we are terrified for the safety of these populations. Here in Nova Scotia, it's not different in other jurisdictions, but up to 80% of the people we incarcerate are on remand, so they're in pretrial custody and have not been tried, have not been convicted, innocent, and are being held in the direct line of fire of this ruthless pandemic. So the work basically is a constant advocacy battle with this province to redirect funding from carcerality, from punishment, this regime, the carceral regime, to more sensible investments, particularly in the pandemic time, but frankly, all the time, in terms of where the evidence of effectiveness and of health support demonstrates for us. So a lot of advocacy, a lot of fear, a lot of real disgust at the choices that our public sector makes with respect to people's lives. But then moments of hope and real inspiration from the resilience of the folks that are persisting despite the threats all around. So that's what's happening in my practice and in my life. Thank you.
Oh, there we go. Thank you very much, Martha, for sharing. Never quite know when I'm on and when I'm not on. We just have a few more minutes before we wrap up today, and I want to reflect and have all of you take a minute to perhaps lead us to where we may go in the future. And you've told us the challenges that you're having. But if we could envision what the future would look like, and if we could make change, if we could, as nurses, build a better future from your perspective, what would this look like? What if we could make the change? What would it look like 2050? Maybe not go out as far as 2070, but maybe 2030 or 2040. What would it look like 5 or 10 years from now? So maybe I'll start with you again, Danielle.
Oh, can we hear me?
Yes, I think so. Yeah, I can hear you.
Okay. Oh, the trouble of always going first. That's a great question. I always get so troubled by these what if questions, but I mean, I think I'm just going to bring it back to a lot of the challenges that I spoke to in my very eloquent speech that I made earlier. I feel like I was really rushed during it because even though we're virtually, I still get nervous out of all the talks I've done. But bringing it back to the education piece that has been mentioned a few times, and I was looking at the comments in the chat box of how seeing participants really horrified by these stories of discrimination and racism. And, you know, when ever since I went into nursing school and started experiencing this form of institutionalized racism and how it manifests in our healthcare system and how our Indigenous people are in a direct harm from it. It also stems from being Indigenous and my family seeing my family go through these exact same experiences, and just really addressing and educating about the racism. And that I've always been, you know, met with a lot of questions about it must be just a one-off experience. That experience that you went through is an individual experience, and we have a lot of these points of resistance from nurses, and it ties into that organizational culture of healthcare and how that normalizes these discussions and normalizes racism and the way things are. Just like as Connie had mentioned, that game that was being played in an ER in BC, and how that's not siloed in that specific area. That is something that's occurring across Canada, and just really getting people to understand the inherent bias and stereotypes that we hold, that we've been ingrained with since, you know, Canada was formed in stolen land. That's where I go when I see these conversations about equity versus equality, and we can't treat everybody the same. And that's why quality isn't enough. It's equity. We need to lead with that equity lens, and that Indigenous people receive today substandard form of healthcare than non-Indigenous Canadians. And we can't treat everybody the same as with respect and as one human race, because we're not on the same starting point as other people. And so just that acknowledgement of racism, that acknowledgement that we need to lead with an equity lens, and that individual accountability and making a change, and not putting that burden on Indigenous people to lead this, to recognize that we are part of this organizational culture, and we need to be individually accountable within our organizations and in our spheres to make that change.
Thank you. Very good insight. Keisha, how do you envision the future?
Okay.
What would it be? What would it look like to you?
Right. So I will build on what Danielle mentioned, just about the institutional piece, because I do think that is so important. So when I think about the work that I'm involved in, you know, the reality is that Black people were banned from pursuing nursing, from entering nursing education until the late 1940s, 1950s here in Canada. Arguably, that legacy of anti-Black racism within nursing still persists today, where we see, you know, significant underrepresentation of Black students in the nursing program, and again, Black nurses throughout the profession, and then up to leadership roles. So obviously, it would be amazing to have more representation across the nursing profession. So at all levels, practical nurse, registered nurse, advanced practice roles, but then also in many care areas. So we do see from the literature that unfortunately Black nurses are concentrated in like non-specialty or entry-level positions, as opposed to being in leadership roles or being in specialty areas. So definitely increasing representation in those areas. But then getting to a place where we're starting to embed policies in institutions and organizations. So this is where it ties on to what Danielle mentioned. So it's not just enough to have allies in institutions, but we really need to make institutional changes, institutional shifts. And if that's not possible, then we have to dismantle institutions. And that is, the reality. So that's one piece. And then the other side, I would say what I envision, and this does go along with having representation in nursing, but it's changing the mindset that the Black bodies, Indigenous bodies, and people of color are inherently a threat and must be, excessive force must be used against them. They must be detained, caged, essentially. So getting away from the idea and the notion that Black bodies are threatening, I believe that is something that is necessary as well. So those three pieces.
Thank you. Very good insight. I appreciate that. Hanalee.
Hi. It's funny because in my music career, because I have two careers, I was invited to be part of this workshop like a few weeks ago. It's called the Utopian Manifesto. It was different musicians from different parts of the world were invited to create workshop and discussed to create strategies to work to promote ideas and strategies to combat discrimination, racism, corruption, and inequality in the cultural sector, specifically in the music industry. And my hope and wish is to have that in the healthcare industry as well, like as a pillar where everyone can participate from different parts of the community, from the Indigenous perspective, from the Black community, from the migrant workers, and so on and so forth. And I wish we have that one day, which can guide us for 2050 to have that idealized community and a society where there's an equity-based approach in terms of our intervention with the disparities in society. And to add to Danielle about education, for me as a settler in Canada, when I came here to Canada, when I was in the orientation on what Canada is, Indigenous history was never part of it. So I would encourage everyone who is part of the audience in this conference to personally educate yourself on the history of Canada that is not, through the Indigenous perspective. And actually, I'm on the third week of my Indigenous studies. I'm doing it personally. There's a free course at the University of Alberta. You can get it through Coursera.org. It's free since you're not doing anything during this pandemic time. You can take it. It's a 12-week course, and I'm on module 3. And I actually have this right just beside my my computer because I had a lesson yesterday actually. So it's free, it's there, the information is out there, and I think the challenge is to just encourage people to do the same, because education starts at home and it starts as an individual. And I'm privileged and I'm lucky to have had like resources that I have now within my community. And quite honestly, it was through the music community, that I was able to have access to those information as well. And I feel like nursing and the arts are sort of like intermingle with each other, because nursing per se is also an art. It's not just a science. And yeah, so I would just like to say thank you to everyone in the panel for sharing, because I've learned a lot as well, and hopefully we'll continue learning as we go. Thank you.
Thank you very much. Appreciate that. Connie?
If you asked me for 2020, my wish would be that we would have equal access to physician and nursing practitioner care, that cultural competency and cultural sensitivity is part of orientation for any doctor, nurse, or healthcare worker, and that the history of Indigenous health is actually taught to nurses and doctors, And I really, hope in the future that we don't bury another young person from this community from carfentanil and fentanyl overdoses.
Yeah, thank you very much for acknowledging the other epidemic that we're dealing with, or the other, certainly epidemic in this province, and the numbers of deaths. And certainly Hanalee has highlighted how we can all educate ourselves to learn more around cultural competency, better understanding of our history. Thank you. And Martha, I will let you have the last word of the day. What would you like to see, or how would you envision the world differently?
We published a piece back earlier in the summer about a nursing vision for the abolition of policing in prisons. And I'm very committed to this work, that justice requires an end to violence, and these institutions in Canada and everywhere are based in legacies of colonial racist violence. And we see it perpetuated. These are institutions that they have to be dismantled if we are ever to achieve health and equity in this country. And I envision a 2050 where, instead of spending $4 billion on incarceration, we use our collective tax money to make sure we're all housed, we're all fed, we're all cared for, we're all safe. That's my vision. Thank you for having us.
Thank you very much, Martha. You speak to my heart. Certainly address the social determinants of health, and we can change the world. Thank you all very much for joining us today. I appreciate your words of wisdom and the leadership that you bring to the nursing profession. It makes my heart be very confident that the future is in good hands. So thank you.